Okay, so you want to own a healthcare diagnostics company. You picture a clean laboratory, rows of automated machines, technicians loading blood tubes into analyzers, and a screen filling with results every few seconds. Doctors send you samples. Hospitals send you contracts. Insurance companies pay for every test. People will always get sick. People will always need answers, and every answer passes through your laboratory before it reaches the patient. It sounds like one of the safest businesses in healthcare. Demand is permanent. The customer usually arrives because a doctor ordered the service. The product can be produced quickly. And once the machines are running, the cost of processing one more sample appears tiny. That is the dream. The problem is that running the test is often the easiest part of the business. The machine may finish in minutes. Collecting payment can take weeks. A sample can arrive with the wrong label. A claim can be denied because one code is missing. A refrigerator can fail overnight. A hospital can move its entire testing contract to a national competitor. A regulator can decide your quality system is not good enough. And one unreliable result can damage the only asset that matters more than your equipment: trust. So let us start at the beginning. Not with the analyzer, not with the test menu, not with the price printed on a patient's bill. Let us start with what a diagnostics company actually sells. Because it does not sell blood tests. It sells information that another human being may use to make a medical decision. And the economics of producing that information are far more complicated than the tube, the machine, and the number that appears at the end. A diagnostic laboratory takes a biological sample and turns it into a report. That sounds simple until you consider what the report must represent. The sample must belong to the correct patient. It must be collected in the correct container, remain within the correct temperature range, arrive before it degrades, and pass through a calibrated instrument using valid reagents. The result must survive quality checks, attach to the correct record, and reach the clinician while it is still useful. The physical test is only one step inside a larger chain. What the customer is really buying is confidence that the chain worked. That is why two laboratories can run the same test and still offer very different products. One may return the result in hours. Another may take days. One may connect directly to a hospital's electronic record. Another may require manual entry. One may collect samples every afternoon. Another may leave transportation to the clinic. The chemistry may be similar. The business is not. The machine produces data. The company produces reliability. Reliability is built through people, logistics, software, documentation, quality control, and repetition. Every one of those systems costs money before the first test is performed. Everyone can fail independently. And the larger the laboratory becomes, the more valuable the network becomes. Because a clinic does not want to relearn ordering, pickup, billing, and reporting every month. The strongest diagnostic companies are not merely places where testing happens. They are systems designed to make testing routine, predictable, and difficult to replace. Before you build anything, decide what kind of diagnostics company you are creating. A routine clinical laboratory processes common blood and urine tests. Demand is broad, volume can be enormous, and prices are under pressure. Speed, automation, and root density matter. An anatomic pathology laboratory examines tissue and cell samples and depends more heavily on specialized interpretation. A molecular or genetic laboratory searches for mutations and other biological markers. The equipment and validation can be more demanding, but useful specialized tests may earn higher reimbursement. Imaging businesses depend on scanners, property, scheduling, and physician interpretation. At-home testing, toxicology, fertility, oncology, and AI-assisted services each have different economics again. For this video, imagine a mid-sized clinical laboratory handling routine testing plus a smaller specialized menu. That exposes the central strategic choice. Do you become a general laboratory that wins through scale, or a specialized laboratory that wins because fewer competitors can answer the same question? A broad menu requires more equipment, staff, validation, and inventory. A narrow menu creates dependence on fewer customers and coverage decisions. The laboratory begins with a test menu. The business begins with deciding which risk you can survive. You cannot rent a room, buy a machine, and begin issuing medical results. In the United States, laboratories testing human specimens for health assessment or diagnosis generally operate under the Federal Clinical Laboratory Improvement Amendments Framework, usually called CLIA. Requirements become more demanding as test complexity rises. A laboratory performing non-wave testing may temporarily operate under a certificate of registration while awaiting inspection, but temporary status does not remove the obligation to build a compliant operation. You need qualified leadership, written procedures, personnel records, training documentation, quality control logs, maintenance records, error handling processes, and evidence that each method performs as expected before patient results are released. Depending on the state and test type, you may also face state licensing, professional rules, waste requirements, privacy obligations, payer enrollment, local permits, and accreditation standards demanded by customers. The facility itself needs reliable power, monitored storage, secure specimen areas, backup plans, receiving space, and physical separation where contamination could affect results. The owner sees countertops and machines. The regulator sees a quality system. That difference matters because the laboratory can look finished long before it is ready to earn revenue. Construction may be complete while an inspection, validation, enrollment, or approval remains unfinished. This is the first cash flow trap. Expenses begin while permission to earn is still being assembled. Now you buy the equipment. For chemistry, hematology, immunoassay, microbiology, pathology, or molecular testing, the machines differ, but the financial problem is similar. An analyzer is never just an analyzer. It arrives with service requirements, calibration material, controls, software, interfaces, consumables, replacement parts, and contracts that may determine which reagents you can use. Some laboratories purchase instruments, others lease them, others accept a lower upfront price in exchange for long-term supply commitments. That can conserve cash. It can also become a trap. If expected volume does not arrive, the commitment remains. If reimbursement falls, reagent prices do not automatically follow. If a newer platform makes your service look slow, the financing agreement does not disappear. And downtime is not ordinary office downtime. When the main analyzer stops, samples continue arriving. Some must be stored. Some must be sent elsewhere at higher cost. Staff remain on the clock. Couriers still run. Customers still expect results. Large operators reduce this risk through multiple analyzers, backup sites, and spare capacity. A new laboratory may have one critical instrument and one service number. The true equipment cost includes every idle hour, repeat test, emergency send-out, and customer lost because turnaround became unreliable. The machine is the visible asset. Uptime is the economic asset. A diagnostic company is also a transportation company. Before a sample reaches an instrument, someone must collect it, label it, package it, route it, track it, and deliver it under the correct conditions. The farther customers are from the laboratory, the more expensive this becomes. But if customers are too concentrated, the market may not support the equipment and staff already purchased. This creates a geographic puzzle. You need enough territory to generate volume, but not so much that couriers spend the day driving between small accounts. The best route is not the one with the most miles. It is the one with the most valuable samples per mile. Large networks build patient service centers, scheduled pickups, regional hubs, and information systems around specimen movement. LabCorp says its couriers make millions of stops each year. That is not a side operation. It is part of the product. A missed pickup can delay many results. A broken cooler can compromise a route. A mislabeled tube can make a technically perfect test useless. A lost sample can force the patient to return. The laboratory then pays twice, first through lost work, then through investigation, recollection, documentation, and relationship repair. The more automated testing becomes, the more important the manual steps around it become. A robot can process thousands of tubes. It cannot repair trust with a clinic whose samples keep arriving late. Now the samples are moving. The instruments are running. Where does revenue come from? Not from one customer. A diagnostics company may be paid by private insurers, government programs, hospitals, physician groups, employers, pharmaceutical companies, research sponsors, and patients. Each group may pay a different amount for the same underlying service, demand different documentation, and follow a different timetable. There may be a list price, a negotiated insurer rate, a government fee schedule, a hospital contract price, a bundled payment, or a capitated arrangement where the laboratory receives a fixed amount per covered member instead of separate payment for every test. At Quest Diagnostics in 2025, revenue came from healthcare insurers, government payers, client payers, such as hospitals and physicians, and patients. No single number called the price explains the business. Test mix matters too. Quest reported that routine clinical testing and related services generated more than half of 2025 revenue, while gene-based and esoteric testing generated a large additional share. Routine work fills the network. Specialized work may improve the economics. But specialized tests bring risk. Coverage can be narrower. Documentation can be harder. A payer may reject the test as unnecessary in a particular case. A guideline or competing technology can change demand. The best revenue is not the amount printed on a claim. It is the amount reliably collected after the work is complete. This is where the business becomes strange. You can perform the work correctly and still not get paid. A claim may be denied because insurance information was wrong. The physician order may not support the billing code. Authorization may be missing. The payer may say the service was not covered. The claim may arrive late. The patient may owe a deductible and never pay the balance. That means the laboratory needs another operation behind the laboratory. Billing staff verify information, submit claims, correct rejections, appeal denials, collect balances, and estimate how much of the amount billed will become revenue. Large companies treat this as a core system, not an administrative afterthought. Quest states that fee-for-service revenue is recorded after considering contractual allowances, historical denials, and collection experience. The number on the invoice is not the number the business expects to keep. Government reimbursement adds another layer. Medicare laboratory payments operate through the clinical laboratory fee schedule. and Congress has repeatedly changed the timing of reporting and payment reductions tied to private payer data. The laboratory controls efficiency. It does not control the national payment system. Imagine a test using $12 of reagent and labor. You bill $100. The contract allows 42. The claim is denied. Your team fixes it. The corrected claim pays 38 weeks later. The test was profitable in the instrument. The transaction was barely profitable in the company. Running the test is the easy part. Getting clean information into the claim and cash out of the claim is where the economics are decided. Diagnostics is a scale business because many costs exist whether you process 100 samples or 1,000. The laboratory director still must be qualified. The facility still needs power. The information system still needs support. The courier route still leaves. The analyzer still requires maintenance. Quality control still runs. Compliance work still exists. Once those costs are covered, an additional test may require only a tube, reagent, a portion of technician time, and unused machine capacity. That is why volume can improve margins quickly. But the unit economics must already work. More tests do not save a laboratory that loses money on every collected dollar. More volume can accelerate the damage by increasing reagent use, courier traffic, billing workload, and denied claims. Quest's 2025 results show how scale behaves at the mature end. The company reported more than $11 billion in net revenue and an operating margin of about 14%. Cost of services consumed roughly 2/3 of revenue. Selling, general, and administrative expense consumed another large share. Even at national scale, the margin was not the fantasy margin people imagine when comparing reagent cost with the amount on a bill. Profit appears only after a vast operating system has been paid for. Scale also changes negotiating power. A large network can offer geographic coverage, connect to major health systems, spread technology costs across millions of requisitions, buy supplies in volume, and move work between facilities. A small laboratory cannot win by becoming a smaller copy of that model. It needs a reason to exist. Strong independent laboratories usually have one of 4 advantages. The first is specialization. A laboratory may focus on a disease area, difficult test, rare specimen, or workflow that general laboratories handle poorly. Complexity is valuable only when it produces an answer customers cannot obtain as easily elsewhere. The second is integration. If ordering sites inside the clinic's workflow, couriers arrive on schedule, results flow directly into the medical record, and support resolves problems quickly, changing laboratories becomes painful. The moat is the cost of disruption. The third is density. 50 customers in a compact area can generate better route economics than 50 customers spread across a state. The fourth is recurring volume through hospital partnerships, health plan access, employer programs, or physician networks. Large diagnostic companies increasingly sell more than testing. Quest reported hundreds of millions of dollars from arrangements supporting hospitals in operating their own laboratories. LabCorp serves physicians, health plans, patients, and biopharma customers. The value moves outward from the instrument toward the network. Then there is data. Longitudinal records of accurate results can support research, drug development, population analysis, and workflow tools within privacy and contractual limits. The hidden profit engine is not the test. It is the position the company occupies between the patient, clinician, payer, and decision. Quality control can look like work that does not produce revenue. You run control material instead of patient samples. You calibrate instruments. You document temperatures. You review unusual results. You repeat tests. You participate in proficiency testing. You stop a run when something looks wrong. Every action uses time, reagents, and staff. None creates a billable patient result, so an inexperienced owner may see quality as overhead to minimize. That is how the business destroys itself. CLIA exists to ensure results are accurate, reliable, and timely. Those are not abstract standards. They are the product. A fast result that is wrong is not valuable. A correct result attached to the wrong patient is not correct. A reliable result arriving too late may have little value. Quality becomes harder as the menu expands. Every new test adds procedures, training, controls, validation, maintenance, and possible failure points. Do not count how many tests the laboratory can technically perform. Count how many it can perform repeatedly, document completely, bill correctly, and defend during inspection. A quality program may reduce short-term throughput. It may also prevent a bad batch, lost contract, corrective action plan, or loss of permission to test. Quality control is not merely the department checking the work. It is the insurance policy protecting the business from its own speed. Now imagine the laboratory is working, volume is growing, customers are satisfied. Then one variable changes. A payer reduces reimbursement on a high-volume test. A physician group joins a health system with an exclusive contract. A reagent goes on allocation. A cyber attack shuts down ordering. A specialized technologist leaves. A competitor offers faster turnaround. A regulator identifies deficiencies. A manufacturer ends support for an analyzer you're still financing. These events become dangerous through repetition. A $5 reduction seems manageable. Across 20,000 tests, it is $100,000. One delayed hospital payment can force you to use a credit line for payroll. One contract loss can leave expensive instruments with no samples to process. Then there is concentration risk. A new laboratory may depend on 3 physician groups for most of its volume. That looks efficient because sales costs are low and routes are dense. It also means one relationship can determine whether the company survives. National companies face many of the same risks, but diversification gives them time. A small laboratory may have no time. This is why an income statement can look healthy while the business is fragile. Profit shows what happened during the period. It does not show dependence on one payer, customer, instrument, specialist, or test. The owner's job is not merely to maximize volume. It is to identify which single failure could stop the entire system. No company illustrates the value of trust more clearly than Theranos. The company promised to transform blood testing through proprietary technology and much smaller samples. According to the Securities and Exchange Commission, Theranos raised more than $700 million while making exaggerated or misleading claims about its technology, business, and financial performance. The personalities made the story famous. The economic lesson is larger. Investors saw a diagnostics company and valued it like a software company. The promise was irresistible. Smaller samples, faster testing, retail access, proprietary machines, enormous scale. If the technology worked as described, the company could sit between millions of patients and an essential medical service. But diagnostics does not allow the central product to remain a story. The result must survive comparison, validation, inspection, and repeated real-world use. CMS records later showed sanctions affecting Theranos laboratory operations, including suspension and cancellation actions connected to serious non-compliance. Once confidence disappeared, branding, capital, partnerships, and narrative could not replace it. A social application can launch with bugs and improve. A laboratory can treat unreliable patient results as an ordinary early product problem. Diagnostics depends on innovation. It failed because innovation becomes an asset only after reliability is demonstrated. The machine can be proprietary. Trust is always public. Now, look at the opposite end of the industry. Quest Diagnostics reported about $11 billion in 2025 net revenue. Diagnostic information services generated the overwhelming majority. The company served physicians, hospitals, insurers, government payers, and patients through routine testing, advanced and gene-based testing, pathology, and related services. The important number is not simply revenue, it is the structure underneath it. Quest reported that cost of services represented about 66.8% of revenue in 2025. Selling, general, and administrative costs represented about 17.8%. Operating income was about 14.1%. That is a scaled diagnostics network, not a machine buying a cheap reagent and selling an expensive test, but a national operation spending billions to obtain, transport, test, report, bill, manage, and support specimens. Testing volume rose sharply in 2025, helped by acquisitions, while revenue per requisition changed only slightly overall. Growth did not come simply from charging dramatically more. It came from volume, mix, acquisitions, and productivity. Large operators buy regional networks, integrate hospital relationships, automate high-volume processes, spread fixed costs, negotiate access to insured populations, and place collection sites near patients. The visible laboratory is only the center of a much larger system. Scale is the moat, but scale is also the burden. A small percentage change in reimbursement, wages, supplies, or volume becomes a very large number. The giant is powerful because it is large. The giant must remain efficient because it is large. Let us build a simplified example. You open a mid-sized laboratory serving physician offices, clinics, and a small hospital contract. You process about 12,000 requisitions per month. Some contain one test, others contain several. After contractual adjustments, denials, and patient collections, average collected revenue is $52 per requisition. That produces $624,000 in monthly revenue. Now subtract the costs. Reagents, collection supplies, controls, repeat testing, and reference lab sendouts cost $170,000. Technical payroll, phlebotomy, accessioning, supervision, and benefits cost $180,000. Courier routes and specimen logistics cost $45,000. Rent, utilities, waste handling, insurance, and facility maintenance cost $55,000. Equipment leases, service contracts, and laboratory software cost $65,000. Billing, compliance, legal, information technology, sales, and administration cost $75,000. Total monthly operating cost, $590,000. Operating profit, $34,000. That is a margin of roughly 5.5% before interest, taxes, and any major unexpected event. The laboratory looks busy. Revenue exceeds $7 million a year. The owner keeps less than $500,000 before financing and taxes. Now, reduce average collected revenue by $3 per requisition. Monthly revenue falls by $36,000. The profit disappears. Or keep reimbursement stable and lose 15% of volume. The fixed costs remain. The margin turns negative. This scenario is illustrative, not an industry average. It shows how substantial revenue can remain highly sensitive to small changes in price or volume. A result is not the same as revenue. Revenue is not the same as profit, and profit is not the same as resilience. Here is the good year. Your laboratory wins a regional clinic contract. Monthly volume rises from 12,000 to 15,000 requisitions. Route density improves because the clinics sit near existing customers. Specialized testing lifts average collected revenue to $56. Automation handles the additional work without staff growing at the same rate. Monthly revenue reaches $840,000. Costs rise, but not proportionally. Total operating costs reach $700,000. Monthly operating profit, $140,000. Now the bad year. One insurer changes coverage rules. Another lowers routine rates. A key analyzer suffers repeated downtime. You send work outside at higher cost. The hospital contract renews at a lower price. A physician group is acquired by a health system using another laboratory. Volume falls to 9,000 requisitions. Average collected revenue falls to $48. Monthly revenue is $432,000. You reduce overtime and routes, but the laboratory director, facility, software, equipment leases, core staff, and compliance system remain. Costs fall only to $520,000. Monthly operating loss, $88,000. The difference between the good year and bad year is more than $200,000 every month. The building is the same. The instruments are the same. What changed was sample flow and the amount collected per sample. That is the volatility trap. Demand for healthcare may be durable. Demand for your laboratory is not guaranteed. So how do you survive? Do not build a laboratory before you build demand. An equipment proposal is not a customer contract. Validate referral sources, payer access, route economics, and billing requirements before locking in fixed costs. Specialize carefully. A complex test earns better economics only when it has clinical value, coverage, and repeatable demand. Diversify. No single physician group, hospital, payer, instrument, or test should be able to destroy the company alone. Treat billing as part of production. The work is not complete when the result is released. It is complete when the information is correct, the claim is clean, and payment is collected. Measure turnaround time and error rates with the same seriousness as revenue. A laboratory cannot permanently market its way around unreliable service. Use automation where repetition is high, but preserve human review where judgment matters. Technology should reduce variation, not hide it. And protect cash. A profitable laboratory can still wait for payment. Reserves provide time to appeal claims, replace equipment, recover from contract loss, and correct quality problems without desperate decisions. The strongest laboratory is not the one with the most impressive menu. It is the one that keeps producing trustworthy results when reimbursement changes, volume moves, and a machine fails. So, does owning a healthcare diagnostics company work? Yes, under the right conditions. It can become a durable business because medical decisions continuously require reliable information. It can benefit from recurring demand, operational scale, specialized expertise, automation, and deep customer integration. A well-run laboratory can become infrastructure that clinics and hospitals depend on every day. But it is not passive. It is not simple. And demand for testing does not guarantee profit for the company performing it. The owner must manage clinical quality, logistics, reimbursement, technology, staffing, regulation, customer concentration, and cash flow at the same time. The laboratory may perform thousands of tests correctly and still struggle because the payer mix is weak. It may have strong reimbursement and still fail because quality is unreliable. It may have advanced technology and still lose because samples never arrive in sufficient volume. The machine is only one piece. The business is the system around it. So if you decide to own a healthcare diagnostics company, understand what you're actually buying. You're not buying analyzers. You're buying courier routes, software connections, payer contracts, trained people, validated procedures, quality records, physician relationships, and the responsibility to produce information that others can trust. The revenue comes from tests, the value comes from reliability, and the entire company runs on a promise that is easy to say and expensive to keep. This result belongs to the right person, and it can be trusted when the decision matters.